So we'll move on to the next lecture, which is also on inhibitors. So we have Dr. Neeraj Siddharthan, who is currently Associate Professor Clinical Hematology, Amrita Vidyapeetham, Kochi. He has done his MD in General Medicine and DM in Clinical Hematology and training in Government Medical College, Trivandrum and CMC Vellore. And his current position is Professor, Head of the Department of Clinical Hematology, Amrita Hospital, Kochi. Dr. Neeraj is also taking care of hemophilia patients and actively participates in most of the hemophilia programs. He is going to talk on 20 years male patient with hemophilia with inhibitors since 10 years and the new drug. What is the role of emicizumab and what are the practical issues? Over to you, Dr. Neeraj.
Thank you, Dr. Chandrakala, and thank you, Farah Madam, for inviting me for this to this forum. So I'm asked to speak on the 20-year-old PWH with inhibitors, and he's been having inhibitors since 10 years, and now we are going to explore the role of emicizumab and discuss the practical issues. So I'm going to call our patient as Mr. H, and so he's been having hemophilia with inhibitors for the last 10 years, and having inhibitors is indeed one of the major complications in hemophilia. So you have experienced a very high burden of treatment, and I expect him to have venous access difficulties. And at his age of 20 years, I think I would expect a low compliance with many of the treatments that he's getting, especially with the IV access. And also, he would want to have a lot of activities, and he would be having a lot of breakthrough bleeds because inhibitors are generally known to have more bleeds than their peers with hemophilia. And I believe his activities would be limited with the breakthrough bleeds, and his protection from joint damage is limited, and of course he would be facing the economics of treating inhibitors because 90% of the cost of hemophilia comes from the treatment of inhibitors with bypassing agents and ITI. So that's why I discussed with him regarding emicizumab, and he asked me, "Doctor, what is this emicizumab?" So I have to explain to him. So I told him that this is a new drug. It looks like factor 8. It works like factor 8, but it is an artificially synthesized, and it is an antibody. What it actually does is that it replaces what the factor 8 does. You have the factor 9 activated here and the factor 10 here, and you have the emicizumab here, which will bind both and then activate the factor 10. So this is essentially what the factor 8 naturally did. So what the factor 8 naturally did, emicizumab is going to do artificially. So, and I told him, see, we have a lot of evidence for this. This drug is marketed. So he wanted to know specifically, what all patients it has been tried. So I told him about having 1, 2, 3, and 4 trials. Basically, it consisted of all kind of patients: hemophilia A with inhibitors, without inhibitors, pediatric patients, adult patients, adolescent patients, and they tried all kind of doses also. All the loading doses were similar: 3 mg per kg for 4 weeks. But the maintenance doses were either weekly 1.5 mg or 3 mg per kg once in 2 weeks, or 6 mg per kg once in 4 weeks. So efficacy was excellent, and because this was compared with other agents without prophylaxis with emicizumab, and there was a significant reduction in annual bleed rate from 89 to 99%. And in all the trials, it was similar, but there were some safety concerns in the HAVEN 1 trial. I'll explain to him in detail, but there were some patients who developed serious adverse events like thrombotic microangiopathy and thrombosis. But that didn't repeat in other trials. We'll go into that. So I told Mr. H that, you could consider this drug because it is approved for your age and you can take it by subcutaneous injection. And it comes in different formulation and the half-life is about 4 weeks. Now, I also explained to him with this graph that, it will take about 4 weeks initially for the drug level to reach a plateau. It steeply rises to a plateau and then it is maintained at the plateau at different ages and at different doses. There are slight differences, but more or less these are being similar. What he was most excited about was that he could take the injection himself. It is a subcutaneous injection, and there was no need for an expertise to get the vein. You could do it himself by injecting in the thigh or the abdomen, or he could get a help of somebody and inject it in the upper arm. So I also showed him, specifically for inhibitors, what is their efficacy. As you can see in this graph, in the hemophilia A with inhibitors, there was almost a 90% reduction in the annual bleed rate. And looking at all the trials together with inhibitors and without inhibitors, very interestingly, the median annual bleed rate, the middle value was 0. So, which means more than 50% of the patients, in fact, it was much more than that, had 0 bleeds with the drug. So Mr. H was very impressed. He said, great drug. But doctor, what about, you said about some safety problems. What are the safety issues of this drug? So I said, yes, we have safety issues reported with this drug in the first trial, HEMLIBRA. First one was the thrombotic events, and there were serious thrombotic events described in 2 patients. And when they dissected that, they found that these 2 patients had received at least 1 dose of APCC while being treated with HEMLIBRA. So, and in both these patients had an average cumulative APCC dose of 100 units per kg per 24 hours for 24 hours or more. So one case was a cavernous venous sinus thrombosis, another was a skin necrosis. And one patient had resumed HEMLIBRA after the resolution of a thrombotic event. But these were the 2 thrombotic events, and after that, no other thrombotic events had been reported. And I told him that even in the recent blood journal publication presented a 2-year follow-up data, and in that also there was no more thrombotic events described. The other complication which I explained to Mr. H was thrombotic microangiopathy. That there were about 3 patients out of the 373 who received Emicizumab and at least 1 dose of APCC they also had received. So there were 31 of those patients, out of which 3 had developed thrombotic microangiopathy. And again, in these patients also, they had received a cumulative dose of more than 100 units per kg for 24 hours or more. So in one of these patients, the patient had a rectal hemorrhage, which was fatal. At the time of the rectal hemorrhage, the thrombotic microangiopathy was improving though. So another patient resumed Emicizumab without recurrence of thrombotic microangiopathy. And as I said again, even the TMA also has not been reported after that, after many safety measures were put in place. So what are the safety measures that we have to consider while giving Emicizumab to any patient? So as a physician, we should tell the patient, and I told Mr. H that you should try and avoid APCC as far as possible when you are on Emicizumab, unless you don't have any other treatment available. But because if you have a recombinant factor 7, then you could use that. For a patient without inhibitor, they can use factor 8, sorry, and a patient with a low titer inhibitor also, they could try a higher dose of factor 8. Sorry. So if sometimes in our country, we can talk about theory, but practically sometimes it may not be feasible, it may not be available, it may be very costly. So now, if at all you are in a scenario where you have to use a bypassing agent and only APCC is available, then the initial dose should not exceed 50 units per kg. It is recommended that generally people would start with 25 units per kg. And the total dose should not exceed 100 units per kg in the first 24 hours of treatment. And you would really have to weigh the risk of TMA and thrombotic events when considering more doses. And these patients, you would definitely want to keep us in patient and monitor for thrombotic events and TMA if you are really having to administer APCC. But as far as possible, try to avoid that. Now, recombinant factor 7 with emicizumab, the trial data was analyzed and although there was a theoretical concern of thrombotic complications, there were no thrombotic events associated with the concomitant use of factor 7 for bleeds and surgery. So the safety profile, dosing intervals, and dosing was consistent with the labeled indication of recombinant factor 7. And in general, this doses of factor 7 also, we start with the lower dose like 90 microgram per kg rather than the 270. So after listening to this, Mr. H was very impressed, and he said, maybe I will try and take emicizumab, but doctor, please tell me about the how I should be monitoring, because now I am checking my in vitro titers and I keep checking that. Previously, I used to check my factor levels. So how do I monitor my laboratory variables? So so this is a little bit tough, I told him, because you have the global coagulation tests to measure. You have the emicizumab levels. You would want to measure the factor VIII activities. You would want to measure the actual inhibitor levels, or you could also look at a scenario where some patients would develop emicizumab antibodies, and then you may want to measure that. So I told Mr. H that, look, when you are on emicizumab, it may look like the emicizumab is similar to factor VIII, and you're getting all the benefits of factor VIII with emicizumab, but you're actually it's not the same. There are a lot of differences between that. To elaborate on that, it will require a detailed session, so I'm not going to go into that, but a little bit. Factor VIII has a short half-life and emicizumab has a really long half-life, and there is some difference in binding with the factor 9, factor 10, and the activated factor 9 and factor 10. Emicizumab will have similar binding affinity to the activated and inactivated factors, but it doesn't bind to bovine. That's going to be important in designing some of the assays. So even this is reflected in the lab tests that we do. So there are tests which are affected by emicizumab, and then there are tests which are unaffected by emicizumab. Activated partial thromboplastin time is usually shortened, by emicizumab. Bethesda assays, the plot-based assays are usually affected. Factor VIII activity is affected. APTT-based APCR is affected. Activated clotting time is affected. Now, the bovine chromogenic assays for Bethesda is not affected. Thrombin time is usually not affected. And the chromogenic-based other factor assays are not affected with the emicizumab. So, first I'll deal with the global coagulation test. I told Mr. H that, look, there are so many tests are there, but practically what we can do is, one is we can do APTT. The APTT before starting emicizumab is going to be prolonged, and after starting emicizumab, it is likely to be coming down and probably normalized, or it will maybe even low. But it is not like a one-to-one, going to be measuring the plasma level of emicizumab or efficacy of emicizumab. But serial monitoring sometimes may help, and it's a very simple test to do. The other test is thrombin generation. And I'm not sure whether many centers will have this, but I told Mr. H that specialist centers will have thrombin generation. It can be either done by ROTEM, so like INTEM and NATEM in ROTEM, or it can be calculated in thromboelastogram, or you could have a standalone thrombin generation assay. So these actually can give a fair idea of the thrombogenicity or the efficacy of emicizumab. So essentially, on your left, you can see the thrombin generation test, and on the right, you have the TEG. And in TEG, from the TEG, you can have the maximum amplitude, and then you have a calculation by which you can actually try and generate the thrombin generation result. So the effectiveness of emicizumab to monitor treatment, sometimes practically we use this, although globally there are different other tests that have been designed. The original Heaven trial used ELISA test to look at the emicizumab levels. However, these ELISA tests were specifically designed for the studies, are not widely available. So many centers have now tried and looked at, looking the old one-stage factor assay and to try and replace with emicizumab calibrator and controls. So I can see that in this graph, it is the one-stage assay replaced with emicizumab calibrator and controls had a fair correlation with the ELISA. So that's one thing which, if some of our labs may be able to do in the future, I guess. Now, if you actually want to do the factor 8 levels while on emicizumab, I'm not sure how many of us really want to do a factor 8 levels while on emicizumab, but if at all, we will have to do, because sometimes it may be needed for a patient who doesn't have inhibitor. So, it is important that, we understand the limitations. If you do a factor 8 assay, you're going to find values like 500 or 1000%, etc. And that's for the one-stage assay as well as chromogenic assay, it's going to be the same. But if you use a bovine factor, a bovine plasma, then that emicizumab will not bind to the factor 10 and 9 in the bovine as previously discussed, and then you could get a proper value there. The same with inhibitors. If you use a classical Bethesda while on emicizumab, you're going to get a false negative values, and so that's not going to be correct. So actually what we should do, if you really want to assess, many people wouldn't want to assess this because the patients are going to do well without bleeds and they are no longer bothered with whatever is the titer. But if you really want to know the titer, because some people are trying to do ITI with emicizumab, a trial is ongoing called Atlanta trial. So if you really want to do the test, then it has to be done by bovine chromogenic assay. So it's a bovine protein-based chromogenic assay for the Bethesda assay while on emicizumab. So, that's a little tough. That's what Mr. H told me. But he has now nevertheless made up his mind that, okay, I may not require much of lab monitoring, but a little bit of lab monitoring, safety is good. If I take good care, then I may not, I have good efficacy medicine. So one last question, doctor, he asked me and says, suppose, I do a lot of biking and, I sometimes are prone to trauma, sometimes, I wonder if I get injured or if I need a surgical procedure, what medicine should I be using? Will this cover if I need a surgical procedure? So I said, yeah, I will need to discuss with you this because you will have to divide surgeries into minor procedures and major procedures. And, the Heaven trial actually looked at their data on minor surgeries, and there were about 141, 215 minor surgeries, and out of which about 141 out of them did not require any support, and this itself was enough. Emicizumab was enough, and some of them actually required additional clotting factor concentrates. So they were divided into dental procedures. So in the dental procedures, out of 42, 29 did not have any bleeds, and 13 had bleeds, and 9 bleeds were treated with clotting factors, and 4 bleeds did not require treatment. So in the venous access device procedures, 23 out of 25 did not have bleeds, and out of 2, 1 was treated with clotting factor and 1 was not treated. Similarly, there was some endoscopic procedure and arthroscopic procedures. Majority of the procedures did not require any factors, and in some of the bleeds did not require factors. So the CFC, wherever the bleed did not require factors, they have mentioned that they have used drugs like tranexamic acid. So that was an important thing. So, summarize the surgical procedures, I think minor procedures, if it's an elective surgery, it's important that you wait for about 4 weeks after the loading dose for the dose to build up. And roughly it is somewhere between 10 to 20% of equivalent of factor 8. I think the level stays. So for the minor surgeries, some of them may not require any further support. In dental, in general, there is a practice that in addition to emicizumab, you give tranexamic acid locally. And if at all you have a breakthrough bleed, then recombinant factor 7 is preferred. And the dose is 90 microgram per kg. And for major surgeries, the CFC support is required mostly. So in summary, I explained to him about the safety and relatively safe, efficacy, very efficacious drug, relatively safe. You have to be cautious with the concomitant use of bypassing agents, and it has been judiciously performed, and recombinant 7A is preferred. Lab monitoring requires expertise in testing and interpretation. APTT and thrombin generation are the commonly available tests right now with us in India, and emerging data on minor and major surgeries with emicizumab alone or with the recombinant factor 7A and emicizumab. With that, I conclude. Thank you very much.
Thank you, Neeraj. That was very nice. We'll quickly go to the questions since we are running short of time. This is from a patient who says that he is on regular emicizumab. If he has an emergency bleed, which should he take, Novo 7 or FIBA?
Yes, madam. So I think I have discussed this during the presentation. The first choice is definitely factor 7A. And if factor 7A is available, factor 7A should be taken at 90 microgram per kg. Whereas if factor 7A is not available, you can start with the FIBA dose of 25 units per kg at a lot of time. But if you are taking FIBA, you should be monitored for thrombosis and thrombotic microangiopathy.
Okay. Can you use emicizumab? This is from Dr. Karim. Can you use emicizumab? Is it beneficial in patients with high titers of inhibitors, for example, 200 beta-sida units?
Yes, indeed. In fact, it is efficacious in both high titers, low titers, and without inhibitors. So inhibitor titer doesn't matter at all because the antibodies to factor 8 doesn't affect the emicizumab functioning.
Right. Is there anything similar like emicizumab for hemophilia B patients?
Yeah, so at present in the market, I think we don't have anything, but and the other bypassing, other non-factor concentrates like fitusiran and concizumab are undergoing trials, and hopefully we should have something approved for hemophilia B in the future.
Yes, so there is something in the pipeline, Dr. Shetty, but I think in a year or two, it should be available even commercially. For long-term treatment of patients, what is more feasible, factor 8 or emicizumab, in terms of efficacy and cost?
So I think this is for a patient without inhibitors. So yeah, that's for a patient with inhibitors. I think we should try and do the cost analysis, because we had done a cost analysis in a couple of patients who were requiring bypassing agents for on-demand therapy, and who had taken emicizumab for 6 months. So we had a 6 months to 6 months cost analysis done, and then surprisingly, the emicizumab time 6 months turned out to be much cheaper than when they used the bypassing agents. So
right. Okay. This is this a future replacement for treatment of inhibitor patients and normohemophilics? Probably yes.
I think
It's
yes.
the cost
Yeah.
of right. There is another question. It's not directly related, but I'll just give it from a Dr. Prasad. They have an elderly patient, age 70, and an 11-year-old patient. Both have hemophilia A mild and both have inhibitors. They say they do not have anything else to treat them with except large factor doses. So what are your suggestions? You know, this actually, I'm sorry, Dr. Prasad, answering this question would be, I think, a whole lecture by itself. And we are planning in the next 2-3 months having a similar webinars dealing with basic treatment of patients, you know, not all the fancy stuff. So I would very much like it if you could sort of attend those seminars, because definitely we will be addressing questions like yours. Chandrakala, I want to go back to the question that we took earlier, because this patient is rather desperate. And Neeraj, you can also try. He is a factor 8 and he says he gets anaphylaxis with recombinant factor 8. What should he do? He's sent the question 2-3 times, so I think we should address it. Any ideas?
Madam, actually, we have one of our patient who has every time we give him plasma-derived factor, he has an anaphylaxis, and we give him only one type of recombinant factor. Not we have many types of recombinant factors with us, but this patient actually responds and with no anaphylaxis, no reaction, only with one type of factor, actually factor 8. So maybe because patient has to see the which type of factor 8 is taking, he might change. If he is having allergy reaction to maybe recombinant one type, he might change to other factor, or he might change the plasma derived. We can't explain. It's mostly we see in inhibitor patients. So we have to confirm he doesn't have inhibitors. If there is no inhibitors done in a proper lab, then he can change the type of factors he's getting. That's the only way we can treat him, madam.
I would also
right. So
yes, ma'am.
Yeah, you want to say something, Neeraj?
No, just that I completely agree with Chandrakala that the high suspicion of inhibitors, because anaphylaxis is, where the immune system responds fiercely. So he should really double check his inhibitor titers.
Right. So, Himanshu, this is for you. So what they have suggested, one is you recheck your inhibitors from a decent lab. And if you are still inhibitor negative, then you try different products and see which one is not going to give you anaphylaxis. I mean, that's the only suggestion we can give, because you're probably getting the anaphylaxis due to something in the preparation that is being given to you. So you'll just have to try and see, because I'm sure it may not happen with all the preparations. So try and see which preparation does not cause anaphylaxis for you, and then stick to that. And with that, we come to close with this. Yeah.
No, he would be a good candidate for Emicizumab if because
right. Yeah, that's the other thing. I thought of it depending on expense, but otherwise you would be a good candidate definitely for Emicizumab. With that, we come to the end of this particular lecture. Thank you, Neeraj, and we go on to the next lecture.